Welcome to SpineView Incorporated's physician training video for the use of the enSpire Interventional Discectomy System. The unique design of the enSpire device offers the advantages of a needle-based procedure while offering disc removal potentially similar to a surgical discectomy. The enSpire system comes unassembled in a sterile peel pack, which includes the discectomy device and one 16-gauge introducer cannula with stylet. Here is the enSpire Interventional Discectomy System. Located on the device handle are the black on-off switch, orange slider, travel limiter with locking ring, and tissue collection chamber with detachable cap. At the tip is a deployable wire and auger, which simultaneously cuts, grinds, and aspirates targeted disc tissue. This disc tissue is transported up the collection chamber. The enSpire device is designed to side cut rather than forward cut, which prevents cutting through the annulus. The device tip with wire is 10 millimeters long and has a 7 millimeter sweep diameter. The enSpire interventional device is equipped with a travel limiter and locking ring, which controls the plunge depth of the device tip. The cutting zone is a combination of the sweep diameter and the plunge depth, which can be set to 10, 15, or 20 millimeters beyond the stationary cannula. The patient is placed in the prone position on the OR table. Pillows placed under the pelvis can reduce the lordotic curve and open up the foramen to target lumbar disc space. Use local anesthetic as appropriate. To establish the correct trajectory for placing the needle, which is the assembled cannula and stylet, you first need to confirm the patient is properly aligned. This can be done with a true AP view. You want to confirm the spinous process is directly in the middle of the pedicles. Align the superior end plate of the inferior vertebrae for the desired treatment level. After proper patient alignment is achieved, the surgeon can use an oblique fluoro shot at 15 to 20 degrees. The physician is looking for Camben's triangle and the Scotty dog. Move oblique until the superior articular process, or SAP, is about 1/3 of the way to the midline. This will open up the window to the disc, and Camben's triangle should be in full view. Once the entry point and optimal pathway are determined, start the needle at the base of the SAP. Take a fluoro shot directly down the barrel of the needle. The margin of the error should be inferior due to the nerve root being more superior. Continue advancing the needle, avoiding the nerve root until you feel an annular pop. If you are not sure of the annular pop, go to a lateral fluoro view to verify. To ensure the needle is properly placed in the disc, take a lateral fluoro shot. The needle should be positioned just past the posterior annulus and into the nucleus, and at the proximal location of the desired tissue removal zone. Once the lateral view is used to confirm proper needle placement, including depth, switch back to an AP view. If the needle is approximately parallel and equidistant to the end plates, this is a confirmation that it's properly placed. Switch to a lateral fluoro view. While continuing to use fluoro, create a pilot hole in the nucleus up to 2 centimeters by advancing the needle to the distal-most position intended for the discectomy device, which is typically the midline of the disc toward the anterior annulus. Now pull back the needle so it is just inside the posterior annulus and again at the proximal location of the desired tissue removal zone. You are ready to perform the discectomy. It is essential that the needle position within the disc be confirmed with 2 fluoroscopic views, AP and lateral. Without using both views, it's impossible to know whether the needle is properly positioned within the disc. Here, the AP view shows the needle is correctly placed. Again, the lateral view looks optimal. Prior to inserting the enSpire device into the cannula, use the skin stop or cannula markings to manage the cannula depth. Carefully remove the stylet from the cannula without moving the cannula. Inject 0.5 cc's of saline without contrast through the cannula. Lock the travel limiter in its fully distal position. Make sure the wire is fully retracted. Attach the cannula hub to the travel limiter hub by rotating the handle in a clockwise direction, with the other hand holding the cannula hub. Prior to activating the enSpire device, please remember, do not make contact with the end plates or annulus. Needle and device should be approximately parallel and equidistant to the end plates. Do not run the device continuously for more than 2 minutes. Always stabilize both cannula and device handle. Activate the motor by pressing the on-off switch to the on position. Advance the orange slider forward to fully deploy the wire. Hold the cannula hub stationary and slowly advance and retract the enSpire device from the handle to begin cutting, grinding, and aspirating the target disc tissue. As the discectomy progresses, the collection chamber starts to fill with disc tissue. Occasionally confirm placement of the device tip using a lateral fluoro. Run the device until a sufficient amount of tissue has been removed. Typically, the device is run a total of 1 to 2 minutes. If desired, the finely morcellated tissue can be removed from the collection chamber for pathology prior to device disposal. The enSpire Interventional Discectomy device is a single-use device and should be disposed of in a biohazard bin following the procedure. In summary, the SpineView enSpire Interventional Discectomy System's unique design offers the advantages of a needle-based procedure while offering disc removal potentially similar to a surgical or endoscopic discectomy. Needle-based access with expandable wire for big results. Selective tissue removal with access to posterior disc through the foramen. Mechanical discectomy facilitates physician control and visual confirmation of tissue. It's disposable and untethered. This concludes the product and technique overview for the enSpire Interventional Discectomy System. There are 2 very important fluoro-related points to highlight. One relates to creating a proper lateral view. The other is the criticality of the lateral view in determining needle depth. Observe on this AP fluoro shot how the cannula looks like it's properly placed. When switching to a lateral view, you see the cannula is actually contacting the superior end plate, which is inappropriate. It needs to be approximately parallel and equidistant to the end plates. Here, the device is too deep. The device must be run in the nucleus, from just inside the posterior annulus and short of the anterior annulus. If resistance is encountered while advancing or you hear the motor slowing, temporarily deactivate the device and assess the source of the resistance. Do not reposition the cannula and device assembly while in the disc. Remove the device, reinsert the stylet, and then reposition as appropriate. Thank you for your attention.